Hello everyone. In this video, we will rapidly review the gastroenterology CCS cases, their diagnostic plan as well as the management. Once we have mastered the gastroenterology CCS cases, we can easily attempt these cases and score greater than 90%. So let's begin. Abdominal pain differential diagnosis. So the differential diagnosis for abdominal pain can be divided into three parts. One is related to liver, gallbladder and pancreas. Second is related to the intestine, and third is related to the kidneys. So regarding the liver, gallbladder and the pancreas. So think about the liver. That can be acute hepatitis. Think about the gallbladder, acute cholecystitis or acute cholangitis. And think about the pancreas. That would be pancreatitis. Next up we have the intestine. The most important thing that can happen with the intestine is acute appendicitis, and besides acute appendicitis we can have small bowel obstruction. And then for the renal or the kidney we have the renal colic. So a quick review of what you have to keep in your mind, so that once you have an abdominal pain patient you have to work up all these causes, right? So start with the liver, hepatitis screen, then go to the gallbladder, acute cholecystitis, cholangitis with an ultrasound, and then go to pancreatitis with lipase amylase. Next, think about acute appendicitis, of course, that will be covered with the ultrasound, and small bowel obstruction with an X-ray. Next up, we have renal colic, that for which you can do an ultrasound KUB. Okay. So cholecystitis. How can you confirm the diagnosis of cholecystitis with an ultrasound abdomen? And of course, there's no need to do a CT scan because you can easily find the gallstones on ultrasound abdomen and the inflammation as well. So for the treatment, first of all, we're going to divide it into three parts. One is the general supportive treatment, since the patient might be vomiting or be nauseous. Therefore, we are going to order ondansetron for the nausea along with IV fluids. Next off, we are going to do some medical management, and that is, since the gallbladder is infected, so we are going to give prophylactic antibiotics such as ampicillin sulbactam. And next off, we have the surgical consult in order to prepare for an interval cholecystectomy if the patient has gallstones, along with the pre-surgical orders. Next up, we have dyspepsia and gastritis. So whenever the patient is having this acid reflux, the initial diagnostic test will be just to confirm whether this patient is having this reflux due to H. pylori. So that would be H. pylori antigen along with urea breath test. And since this is like simple acid reflux, we will avoid doing an endoscopy and try conservative management first and see if the patient improves. And then the specific treatment for like this symptom control would be pantoprazole after we have the diagnosis of reflux, and we will avoid NSAIDs since they can aggravate the gastritis and dyspepsia, and give acetaminophen instead. And if the patient has chronic arthritis, it's very important to refer to orthopedics for the permanent treatment, because the patient cannot be taking chronic NSAIDs. If he continues to take chronic NSAIDs, his stomach dyspepsia and gastritis would become even more aggravated. Okay. Next off, we have duodenal ulcers. So if the patient is presenting with low blood pressure and dizziness, right? So first of all, we have to establish again the cause, that it's really a duodenal ulcer. So if it's ulcer, it might as well be bleeding, right? So we have to get an occult blood stool test, right? Occult blood stool test in order to look for the presence of blood in the stool. Next off, we have to visualize the ulcer and confirm that it's there, if there is some sort of bleeding actively happening with an endoscopy. And if, of course, you are suspecting a perforation, you can get a chest X-ray done. Next off, we will find the cause. So what is causing the duodenal ulcer? That would be H. pylori antigen and urea breath test, right? So confirm the cause with fecal occult blood test along with an endoscopy, and rule out complications such as perforation with chest X-ray, and then find the cause with H. pylori antigen or urea breath test. Then comes the specific treatment. Of course, if it's H. pylori infection, you're going to treat him with clarithromycin, amoxicillin and pantoprazole. And the supportive treatment with IV fluid, since the patient might be having low blood pressure and dizziness, and then consult gastroenterology. Okay, next off, we have a perforated peptic ulcer. So this is the same ulcer, but now since it has perforated, so it's an emergency. So quickly you have to get the chest X-ray and to look for air under the diaphragm. And again, this will just confirm the cause. So this will just confirm a diagnosis. In order to confirm the cause, we have to get an H. pylori antigen test. Now, right now, we'll treat with the H. pylori thing in later. Right now, since the ulcer is perforated, right, so the patient has acute abdomen. Therefore, we have to do like some general surgical years, and that would be, of course, make the patient NPO and give him like an decompressed with NG tube along with giving an IV fluids, right? So there is a small mnemonic that I have made for whenever we have the acute abdomen that requires surgical treatment, that we are going to make the patient NPO, we are going to insert NG tube. Of course, there will be exceptions which we will discuss where we are not going to insert NG tube, right? So this is when the patient has to go for surgery and then there is an acute abdominal cause, right? And then of course, like, give the patient fluids, do a surgical consult. So this is NNF, that's the general mnemonic for an acute abdomen that is requiring surgery, and we will go through it like in the other cases as well. And then of course we are going to do some surgical management, that would be surgery orders and consult, and then the nice PT pre-surgical orders along with empirical antibiotics such as ampicillin, sulbactam or piperacillin, tazobactam, just like we gave for acute cholecystitis. And of course it's possible that the peptic ulcer happened because of NSAIDs use or aspirin use, so we are going to counsel the patient to advise aspirin and NSAIDs, avoid aspirin and NSAIDs in the future. Next off, we have acute pancreatitis. So again, like, think about acute pancreatitis. What can we do in the blood? What can we do radiologically, right, to confirm that this is really acute pancreatitis? So one specific test in the blood would be, of course, lipase and amylase. But besides this, in the blood, if you want to find out the cause, so it might be caused by ethanol use, right, or it might be caused by hypertriglyceridemia. Therefore you want to get the lipid levels done along with serum ethanol done. Next off, so you want to do some radiological tests, again, to rule out that the pancreatitis is maybe not being caused by gallbladder, or it's not causing, like, there is no acute perforation of the duodenal ulcer, right? Therefore you want to do an x-ray of the abdomen along with an ultrasound of the abdomen. So for pancreatitis, think two ways, right? For the goals of diagnosis are to do some blood workup along with radiological workup. Now to the treatment, of course, you're going to make the patient NPO if needed, the NG tube. Well, he's not going for surgery, so we might not need that much of surgical decompression, but since this is acute abdomen, we are definitely going to make him NPO along with IV fluids. And of course he might be like vomiting, so give ondansetron. And acute pancreatitis, the pain is so severe, give morphine, right? This was the general supportive treatment. Now for treating the cause. If the patient specifically has cholelithiasis and the gallstones are like obstructing the duct and they are like the pancreatic outflow and they are causing this reflux pancreatitis, then you're going to get an emergency ERCP done. Then, or if the patient has gallstones, then elective cholecystectomy and surgery consult, and of course GI consult. Next off, we have celiac disease. So again, not only do you have to establish the diagnosis of celiac disease, but you have to rule out other things as well. So whenever you think about celiac disease, think about four main things. Number one, confirm the diagnosis of celiac disease. How? Of course, like by doing anti-endomysial antibody. So there's this antibody test that you have. Then you can do an endoscopy along with the biopsy of the small bowel. So this is the first goal, establish the diagnosis. Next off, you are going to establish the associated deficiency. So you know that celiac disease is a malabsorptive disorder. So it's possible that there are some vitamin deficiencies. So get A, D, E, these are the fat soluble vitamins along with B12 and folic acid levels, right? So A, D, E, B12 and folic acid. Next off, do some other like micronutrients like deficiencies that include copper, zinc, iron and ferritin. So these metal deficiencies. And then we have bone densiometry. Again, due to vitamin D deficiency, it's possible that the patient has low bone densiometry. Okay, so that would be the associated deficiencies. Next off, like some more confirmatory labs that are going to again support a diagnosis, that would be the presence of fecal fat. Again, that would tell us that it's a malabsorptive state. And for some stool tests, of course, we are going to rule out some sort of stool infection with ovine parasites, stool culture sensitivity and stool gram stain, right? So for sorry about that. For celiac disease, think four main things. One, confirm the diagnosis with endomysial antibodies, endoscopy and biopsy of the small bowel. Two, find the associated deficiency with vitamin A, D, E, B12 and folic acid along with the micronutrients deficiency, copper, zinc, iron along with the ferritin and bone densiometry. Next, look for some associated confirmatory labs that will confirm that it's malabsorptive with the fecal fat, and do the stool tests for oviparasite culture and gram stain to rule out infectious causes, right? And the treatment, you know that there is one just specific treatment that is for one specific treatment for celiac disease, and that is the diet. Once you eliminate the gluten, the patient is going to start getting better. And of course, any associated deficiencies such as vitamin D deficiency need to be treated, and the consultation for nutritionist is also important. And then for the prevention, since the patient might be having hypersplenism, you're going to give him pneumococcal vaccine. Next off, we have IBS. Again, you know for IBS that this is a diagnosis of exclusion. So think in your mind again, four main things. The four main things that you can rule out, and after ruling out the four main things, you can establish the diagnosis of IBS, right? So what are those four main things? Think infection, inflammation, antibody mediated, and constipation. Or you can also think of it like IICC, right? So IICC is infection, I infection, I inflammation, C celiac, and C constipation, right? So first of all, think infection. Okay, how can I rule out infection? With the stool culture, so of course, stool antigen, oviparasite, stool gram stain, right? How can I rule out inflammation? I can rule it out with ESR and CRP. How can rule out constipation? X-ray of the abdomen. How can we rule out celiac? You know, with the antibodies along with, if needed, an endoscopy along with a biopsy, right? And once everything is negative, now you know for sure that this is just IBS. Therefore, you know, if the patient has like for the symptomatic management, if you think that the patient has diarrhea, he's going to get loperamide. For the treatment of constipation, he's going to get a high fiber diet, right? And in order, like the general supportive management is that if the patient takes exercise program, has relaxation techniques, then that is going to help with the IBS, because you know it's psychiatry or an anxiety related disorder, right? And then we're also going to consult nutritionist and avoid colonoscopy, because there is no indication for colonoscopy. None of our screening tests actually came back positive, so we do not need to do colonoscopy. Just the symptomatic management with a high fiber diet, loperamide, exercise program, and consult nutritionist. Next off, we have Crohn's disease. Again, for Crohn's disease, one would be the confirmation of the cause. So again, it's a malabsorptive disorder, so it will have associated deficiencies, just like we did for celiac disease. And third, we are going to rule out infections, and of course, like you can do a fecal fat test as well if you feel that there is the need and it's a malabsorptive disorder, right? So for confirming the cause, just like we did for celiac disease, what are we going to do here? A colonoscopy for looking at the large ball involvement, and endoscopy for the upper GI involvement. So if we know that Crohn's disease can occur from the mouth to the anus, right? So the associated deficiencies with Crohn's can be iron, vitamin D, and B12, and rule out infections with stool culture, stain, ovine parasites, and of course get malabsorptive tests of fecal fat. And the specific treatment, you know that this is an inflammatory disorder. Therefore, the specific treatment would be prednisolone, and it's possible that you might need to consult gastroenterology or surgery if you need to do surgery, okay? Then next off, we have diverticulitis, right? So there is an acutely inflamed diverticulum, right? And first thing first, rule out that the patient does not have an acute perforation, right? And for that, you will get an X-ray of the abdomen. Once you know there is no acute perforation, follow up with the CT abdomen, and the CT abdomen is going to tell you that there is an inflammation of the diverticula. For the treatment, of course, we are not going to do surgery acutely. So from the NNF mnemonic, we are just going to do NNF, right? We're going to put him on NPO along with give him eye fluids. For the specific treatment of the infection, we are going to give amoxicillin clavulanate or ceftriaxone with metronidazole. And there are three things that you're actually going to avoid. So the second N that we had over here of NG, that is what you're going to avoid. And why is that? Because the diverticula over here is acutely inflamed, right? Which means that the gut wall is susceptible to perforation. So how do we prevent the perforation? Don't do a colonoscopy. Don't do an NG tube with suction. Don't do a barium enema, because all of these can make the colon susceptible to perforation. So there was no perforation before, but by doing a colonoscopy or NG tube with suction or barium enema, you might actually give the patient a perforation. So don't do these, right? And if the patient has, of course, signs and symptoms of fever, and you find out on CT scan that the acutely inflamed diverticula is actually an abscess and greater than 4 centimeters, then of course plan for the surgical drainage of the abscess as well. Next off, we have acute hepatitis, right? Again, for acute hepatitis, just like we did previously, think about blood and think about radiological, just like we did for the acute pancreatitis, right? So blood, what can I do in the blood to rule out acute hepatitis, or confirm the causes rather of acute hepatitis? That would be doing the hepatitis panel, right? And similarly, it's possible that acute hepatitis is caused by acetaminophen overdose, right? So you can get an acetaminophen toxicity normogram done, or you can also like get serum acetaminophen levels done. And then for the radiological, for the acutely inflamed liver, looking at the acutely inflamed liver, you want to get an ultrasound of the abdomen done. And the specific treatment, you're going to avoid acetaminophen liver failure, because it's like, of course, going to exacerbate the liver failure. And besides this, like general supportive management with the ABC, right? And if the patient is vomiting, on dansetron, and push the patient on NPO and IV fluids and all those supportive measures. Next off, we have ischemic colitis, right? Again, for ischemic colitis, like think about those two things that we did for acute diverticulitis, right? For acute diverticulitis, there was more of an infection and inflammation. In ischemic colitis, there is more of an ischemia that is causing it. But the diagnosis remains the same. We will rule out the perforation with X-ray abdomen. Then we will confirm the cause with CT abdomen. For the treatment, of course, the general supportive measures that we have been doing, right? And NF, because ischemic colitis is going to go to surgery, because we have to clear out that ischemia. Otherwise, the gut is going to become ischemic, necrotic. The patient might as well die of sepsis, right? Therefore, NNF with NPO, NG tube as well as IV fluids. There is our NNF. For ischemic colitis, of course, there is ischemia and there is increased chance of the multiplication of bacteria and infection. Therefore, give broad-spectrum antibiotics such as piperacillin, tazobactam, or cefepime and metronidazole. And then, of course, we are going to send the patient to surgery. Therefore, surgical consult, pre-surgical orders, along with the gastroenterology consult. Next off, we have intussusception. So now we have a baby, and this baby has like some sort of one part of the gut going into the other part of the gut, telescoping basically into the other part of the gut. So again, for any the patient who is presenting with acute abdomen, always rule out the perforation first with X-ray abdomen, fast forward to the results and find out that there is no air under the diaphragm, and then get an ultrasound of the abdomen that is actually going to confirm the cause of intussusception. For treatment, of course, the patient is going to surgery just like for ischemic colitis. So NNF, NPO, NG tube with surgery along with suction, NG tube with suction along with the fluids. And the definitive treatment, of course, it's possible that the patient might become better with barium enema, and it's possible that he might need to be operated, right? So give him a barium enema, and at the same time consult pediatric surgery in case the barium enema fails. Next off, we have neonatal jaundice, in which we have a neonate who has unconjugated hyperbilirubinemia. So first thing first, you have to get, of course, like the bilirubin levels. That's why you came to know that this is unconjugated hyperbilirubinemia, and get CBC done, which will of course show low hemoglobin, and for the Coombs test if there is some sort of hemolysis going on. And the treatment is of course supportive. You are going to admit the patient to the inpatient unit and give him phototherapy, and in the prevention, of course, you are going to advise the mom to continue to breastfeed, and if like the breast milk is insufficient, advise the infant formula, so that like it improves the enterohepatic circulation and helps the bilirubin to get cleared out and the jaundice to become settled. Next off, we have colon cancer. So if the patient has colon cancer, like or any cancer, what are the three main things you're going to think about? So the three main things would be, first of all, you want to establish a histopathological diagnosis. Second off, you want to establish a radiological diagnosis along with looking for mets. And third off, if there is some sort of tumor marker, you want to do a blood test, right? So there are three things you want to do: a histopathological diagnosis, a radiological diagnosis, along with blood test. So the histopathological diagnosis would be colonoscopy and biopsy. The radiological diagnosis would be chest X-ray for mets, CT abdomen, pelvis, and chest for mets, and the blood tumor marker would be CEA, carcinoembryonic antigen. For the treatment, of course, like for any carcinoma, you are of course going to counsel the patient along with giving him, like there can be a surgical treatment or there can be a chemotherapy treatment. So surgical consult along with oncology consult, and of course in the prevention, cancer counseling, so that the patient, like the occasional fecal occult blood tests or occasional colonoscopies to see that the cancer is not actually coming back. Next off, we have pancreatic cancer. And just like colon cancer, we'll keep those three things in mind, that can we get a histopathological diagnosis, can we get a radiological diagnosis, and something that we can look for in blood, some sort of tumor marker. So histopathological diagnosis. Of course, pancreatic cancer is not possible to, biopsy it with an endoscopy. So that's excluded. So how are we going to establish the diagnosis? Through radiology. So that would include getting an ultrasound of the abdomen, CT of the abdomen, and then CT of the chest for myths. And next off, of course, the associated tumor marker that would be in the blood, that is lipase. For the treatment is the same. Counsel the patient regarding the cancer diagnosis, consult oncology, consult surgery, and then ERCP in order to biopsy and in order to relieve the jaundice if the patient is actively jaundiced. So that concludes our CCS Gastroenterology Rapid Fire Review. If you like this video, please like, share, and subscribe, and follow for more. And I'll see you in the next video. Happy studying!